Hello everyone, and I hope everybody is doing perfectly fine. So today we'll be discussing an important topic, that is pilomatricoma, a skin and neck cell tumor. So this case actually, I was going through few cases in my lab, Atharva Diagnostics and Care. So this is just like my third baby. So I've started when I started with my lab, I thought I would start with histopath also. So now, like when I do my histopathology, so some cases are there which I keep on coming across. It comes to my mind that these cases should be discussed so that it helps us all in reporting in our day-to-day practice. So that then I thought, yes, some rare cases. So what I'll do is I'll keep on posting few rare cases which I come across at my center, and then we'll discuss with you all. So in this sacred space, this line, I was going through today's newspaper, then I got it, that to know that we know what we know, and to know that we do not know what we know. That is the self-consciousness in us. That जो हमें पता है, हमें ये पता होना चाहिए कि हमें पता है, and हमें ये पता होना चाहिए कि हमें नहीं आता है. So this is basic mantra which every student should follow, that yes, if I know, I don't know the topic, I don't know. I should not like कि कुछ भी आप आंसर लिख रहे हो या कुछ भी I should talk about that topic. Suppose if I don't read what is pilomatricoma and just go on saying anything, so that is baseless. So that is the crux I wanted to share with you all, that we should have true knowledge. Whatever we are reading, read it clearly with all the like concept should be clear, and then we can, so that when you talk about the topic, so you are the boss, that you know at least every from bits to the maximum, you know what you which topic you are talking about. So that is, this was said by a famous Polish astronomer, that is Nicholas Copernicus. इन्होंने हमें बताया, he led to the final that clearance that yes, it is not the earth around which everything revolves, it is the sun in the heliocentric center, that heliocentric basis, the sun is at the center and all the planet including the earth revolves around it. So main idea of telling these few lines from these famous person was to that we should have focus and we should have clear knowledge. To whatever topic we are reading, we should be thorough with it. So coming back to the case, so this was a case of a 26-year-old male patient. He presented with swelling in the left arm and it was for the last 1.5 years. And the swelling was gradually increasing in size, soft to firm in consistency. It was mobile, not fixed to the underlying structure or to the overlying skin. It was non-tender, and the patient did not have any significant past medical or surgical history. So excision of the swelling was done, and the lesion was sent for detailed histopathological evaluation. So this is what we received on gross. So we received a single small round to oval tissue mass which measured 2.5 into 2.5 centimeter. Here we can see a round to oval mass. External surface is grey brown, as you all can see, with patchy yellowish and patchy blackish discoloration. So this was the complete excised mass which we got. So when we gave the section, so we gave one slice section and divided it into three sections, and then we started it. So it was stained with HNE stain, that is hematoxylin and eosin stain. And the sections which we examined showed sheets and layers of anucleate squamous. So as we all know how a squamous cell looks like, it's a large cell with clear cell membrane, and then you have the nucleus at the center, you have abundant eosinophilic cytoplasm. So all the nuclear membrane, cell membrane are very clearly defined. So घोष सेल हम उनको बोलते हैं जिसमें सिर्फ anucleate squames रह जाते हैं. So they don't have a clear boundary whether it is cell membrane or a nuclear membrane. So you cannot see, you can see just anucleate squames. So these cells show outlines of eosinophilic shadow cells showing central pallor indicating host nucleus. We will see कि हाँ nucleus तो है, but it's like a primitive type है, nucleus है नहीं but stained नहीं है वो. And you can see foci of calcification also we saw in these sections. So mildly inflamed, we saw mild inflammation comprising of chronic inflammatory cells And focus of benign squamous cells was also seen, and that gives you the origin. Yes, origin is from the squamous cells. And we saw occasional giant cells also, multinucleated giant cells. And extensive grossing, sectioning, and studying the sections, we did not get any nuclear atypia or mitotic activity in all the sections which we examined. So see, here what you are saying, marked lands and islands of squamous cells there. But when you cannot appreciate the cell membrane, it's like a pale islands of squamous cells here, here, here. I'll show you the high power also. See, these are all islands there of the squamous cells, which is like they don't have any proper cell outline. So here you see, you are appreciating, yes, nucleus is there is cell membrane, but it is not. So it's apparently, it's like ghost. So इसी को हम कहते हैं ghost nuclear cells. So these are all the ghost cells which is replacing the entire squamous cells, sheets of entire squamous cells. Correct? So here you see, so apart here, यहाँ पे islands of anucleated squamous cells हैं. Sheets of ghost cells are there here, and what we are seeing in between is a multinucleated giant cells. So two giant cells we can appreciate in the sections. So this is the summary of all the images I have shown you. Here we saw the islands of the anucleate sheets of squamous cells. Here is the high power of the same. You can appreciate that yes, nucleus was there, but we cannot properly, there's no evidence of clear nucleus. So it was there, but now it is destroyed. So here you can see a multinucleated giant cells, and in some section in the fibroadipose tissue, as I told you, we saw mild chronic inflammation. So this diagnosis, what we gave is left arm excision swelling was done, and the diagnosis is your pilomatricoma. So this is a basically skin adnexal tumor. So now the final diagnosis is made. So why it is important? See, so I'll tell you in gradual the slides why it is important. So it was first described by Malherbe and Trenchias in 1880. And initially they described it as what? It's a benign neoplasm, obviously, originated from sebaceous gland. Later in 1969, the term pilomatricoma was assigned to this lesion by Jones and Campbell. And also this entity, the pilomatricoma, is also known as pilomatrixoma, and also known as, the name looks heavy, right? Calcifying epithelioma of Malherbe. When in PG days, we used to write it. We used to think that what diagnosis we have made. It's so heavy. So calcifying epithelioma of Malherbe. So it basically, what is the origin? It arises from your hair follicle matrix, hair cortex, follicular infundibulum, or it can arise from your outer root sheath and hair bulge. So coming to the incidence, it has incidence, a bimodal peak incidence. Okay, it can occur usually seen in first and sixth decades of life. So extremes of ages it has, and it usually develops within first 2 decades of life. With 40% of case, you will see it occurs before the age of 10, and 60% of the case 60% of the case occur before the age of 20 years. So usually solitary, but up to 3% you can see they have multiple. So how it presents? It's a benign, cutaneous, firm, solitary lesion, and usually seen on face, neck, and upper extremity. Our case was also on the left arm. So at times why it has become difficult to diagnose this entity. So you can say कि इसमें तो नहीं दिख रहा nucleus और ये, so straight away we can give a diagnosis of pilomatricoma? No. So you have to do points to remember. You have to do extensive grossing. Okay? So to rule out कि वो कोई, and also technical error कि staining defect तो नहीं है. So what we'll do, you have to remember this entity in mind while reporting कि yes, अगर मैं बोलना चाहूँगी ये staining की वजह से हो, less खराब staining की वजह से है कि these cells are not stained. So that will save my time if I know this entity, pilomatricoma. In all sections I'm seeing these cells only and multinuclear giant cells. So retrogradely I can think that yes, there is an entity, this pilomatricoma is there, so I can make a diagnosis of it. Fine. Then might present benign lesions की तरह mimic कर सकता है, like keratoacanthoma, ossifying hematoma, fibroxanthoma, or malignant lesions like squamous cell carcinoma. You may think there may be necrosis, because of which all these cells are not in their proper architecture. So this rules out. So diagnostic identification is very important, and per se this pilomatricoma अगर recurrence में है, तो very rarely, like very few cases have been reported of pilomatrix carcinoma also. So for this you can say कि हाँ, correct diagnosis and keeping the patient in follow-up So that is also important. So we can consider sometime a benign lesion here, but it holds importance in diagnosis. You can miss it. You can miss it, or you cannot give a correct diagnosis if you don't know the entity. So location 50%, as I told you, it occurs in head and neck and followed by other areas, it's upper extremities, trunk and lower extremities. Macroscopic examination, how it grossly, जैसे हमें मिला था, it's like a well circumscribed nodulocystic tan colored mass, same we got brown, black discoloration, yellowish area, and containing irregular shaped lobulated islands of cells when you cut section. So they are like finely separated by the fine fibrovascular connective tissue stroma. So here comes the crux and the importance of histopathology. So histopathology has its own charm. So histopathology provides a definitive diagnosis of this lesion, and classic histology, what we got in our case also. So we got presence of ghost or the shadow cells we call it, or the basophilic cells we call it. Low bar pilomatricoma will appear as well circumscribed nodulocystic. जैसे हमने देखा अपने केस में कि islands of जो squamous cells हैं which are not having their proper nuclei and the membranes haphazardly arranged. So islands of squamous cells you are seeing and the tumor and mostly noted in the lower dermis, but extension into the subcutis can also be. So microscopically, that is the typical islands of eosinophilic cells which are derived from the basaloid proliferation. As the tumor matures, the basaloid cells degrade. Centrally, they form a anucleated host in host cells, shadow cells, all these due to the unstained region. So because they don't have the proper nuclei or the cell membrane, so stain nahi le gaye. And at times we can see calcification within the shadow cells and we can see presence of multinucleated giant cells as we saw in our case. So treatment part here, once you diagnose, give a diagnosis of pilomatricoma, what the surgeons are going to do is they are going to surgically resect the tumor, but what you have to, while evaluating, what you have to keep in mind, you have to exclude all the, why extensive grossing, sectioning and examining the slides are important, because we have to rule out many other entities before we arrive at diagnosis of pilomatricoma. So epidermal inclusion cyst, we have to rule out, ossifying hematoma, giant cell tumors. So all these, they have their typical histological features: chondroma, dermoid cyst, foreign body reactions, degenerating fibroxanthoma, metastatic bone formation, osteoma cutis. So all these clinical conditions should be ruled out by extensive grossing, sectioning, and evaluation of stained slides. So these are a few of my references. Thank you so much for your patient hearing. Kindly like, subscribe and share my channel, Patho with MK. Thank you so much.